Welcome, Meng.
Thank you for having me, Paul. Really appreciate you inviting me to give this talk.
Well, I'm really thrilled. You have been very fortunate to train under Mike Huang at University of Miami, and now you're really spearheaded the minimally invasive and endoscopic spine program at Houston Methodist. So tell us just a little bit how you got started and how you got facile with this Trans SAP approach that we're going to talk about today.
Yeah, so I trained here in the very department that I am faculty at Houston Methodist. I've had a lot of minimally invasive training all along the way. A lot of that was with my senior partner senior mentor and now partner, Paul Holman. Did a lot of tubular. So there's got to be an even better way to do what we do. And of course, endoscopy has already gained traction in other parts of the world for a long time now. But I noticed that Mike Wang was doing quite a bit of it at Miami. And so I went down to interview with him, and I really was hooked. And that's sort of my foray and journey into the endoscopic realm. Um, so obviously I had Mike to thank for my introduction to endoscopy. And then of course, through Mike, I was able to get connected with a lot of the other leaders in the field, like yourself, for example, at the courses. And so, through the small, tight-knit network of outstanding endoscopic surgeons across the country, I was able to continue to stepwise build my skill, and then just decided that I would really kind of take off with it. And I was tasked with building the endoscopic program at Medist, and I've had really good partners and backing all along the way, and just took off with it. I've been fortunate to really kind of understand it well, and I've been taught well, and so it really sort of I would say came relatively easily. Although the first 20 cases were definitely challenging, I feel like I hit my stride pretty quickly. So very very big fan of endoscopy, and delighted to have the opportunity to be on your How I Do It approach. I've been following it for a long time, and heard the other greats of endoscopy give their talks. So it's certainly an honor to be featured here, and thanks for having me.
Oh, well, you're very welcome. We're really excited to have you because, we try to get the word out and teach maybe different approaches. There's many different ways of targeting. And you're going to talk to us today about the Trans SAP approach. So why don't you go ahead and tell us how you do it?
The Trans SAP, the Superior Articular Process Approach. And let me go to my next slide. So we sort of touched on this a little bit. Obviously, I have to give credit where credit is due, and thanks to Mike for teaching me the basics of transforaminal endoscopy. And Christoph Hofstetter was the one who really taught me the Trans SAP approach, and he outlines that very nicely in his book. This is a picture of us at a course in March where I was still the attendee back last year, and this is where I really picked up this approach. And then I do want to highlight and give kudos to Paul Holman, my mentor since I was a fourth year medical student, now my senior partner. I think one of the challenges of starting an endoscopic program, especially when you're just starting out, is really having the support, and people believe that this approach that they've never seen before could actually work. And so Paul has been instrumental in giving me the backup I need, and also getting me involved in the complex cases that he thought that it would be a good challenge for us to attempt to endoscopically. And we've really grown the program, and he's doing a ton of endoscopy now too. So credit to where credit is due, first and foremost. So I just wanted to briefly touch on Camben's prism. So Camben's triangle, obviously everybody understands the traversing nerve root, the exiting nerve root, the figure. And I think it's classically thought of as a two-dimensional space because traditionally, transforaminal surgery is mostly thought of as a TLIF. And so by nature of a TLIF, whether you do it open or MIS, you are already automatically removing the SAP. So that part of the foramen is already gone automatically in your mind. And so when you think of a transforaminal approach, I think the triangle typically makes sense. But Fanous, Timmy Allen, and Mike, of course, reclassified the Camden's triangle with the idea of endoscopy in mind. And so they classified this as a prism because naturally the SAP is the three-dimensional component, the roof of the triangle, and therefore the prism of access. And so when you're talking about Camden's axis, there's three different sub-axis groups of type 1 axis, which is really what we're talking about here with transforaminal endoscopic surgery. Type 2 and 3 are more expanded transforaminal corridors that you would see in traditional MIS and open TLIF techniques. So for Camden's type 1A axis, that is essentially a straight-on parallel target into the disc space, and it's really traditionally used for endoscopic assisted TLIFs, so endo TLIFs and those approaches. The 1B axis is the more traditional needle targeting transforaminal endoscopic decompression type of approach, and that takes a more of a rostral to caudal approach, and you're targeting the caudal medial border of the prism. And then the Trans SAP axis is the 1C axis. And that is essentially the same thing as 1B, except you're docking on the ventral lateral aspect of the SAP. And even though this is classified differently and is known as a separate axis technique, I really honestly think 1B and 1C are really the same thing if you really boil it down to the components. And so I'll go into more of that in a second here. So indications. So same indications as your 1B axis as and any of your transforaminal axis for endoscopy. Foraminal stenosis. You can access central and paracentral disc herniations. You can access even foraminal and extraforaminal disc herniations, Trans SAP. I know that kind of sounds like it doesn't make sense. Why would you go Trans SAP to get something outside of the foramen? But really, I think the Trans SAP docking and targeting is actually safer because you are essentially creating your foraminoplasty and docking and reaming into the SAP in a situation where if there is a foraminal, extraforaminal disc, the nerve root may be dorsally displaced and closer to your traditional 1B axis point. Lateral recess stenosis obviously can be addressed. You can address abscess, phlegmon, epidural tumor. So really you can do anything with a Trans SAP approach, I think. Advantages, in my mind, decreased risk of DRG injury irritation. Trans SAP, you basically have a laser sight in through bone, you're docking on bone, you're reaming through bone. So I think the risk of aberrant reaming is much less with the Trans SAP approach, and you automatically get that higher volume of upfront foraminoplasty. And really, I mean, that's what you're trying to get with a traditional needle access too. It's just that with the traditional needle access, if you're a novice and not an expert like yourself, then maybe you might slip off of the SAP, especially the portion that you're trying to ream, and really go into the foramen. And if there's a situation where it's a tight foramen, that may cause a DRG injury. With a Trans SAP approach, I think you have a more dorsal view of the lateral recess, so doing canal work becomes much easier, I think. And therefore you also have the ability to reach more central pathology. Disadvantages, all really theoretical, I think. Increased risk of traversing root injury with a Trans SAP approach. Your target, the end of your target is really the lateral recess. So you're targeting the lateral recess. Most of the time, though, I think if you're going for any sort of pathology in the lateral recess, the root is dorsally displaced. And so I don't think that's really a major a risk.
Yeah, plus with any of these approaches, when you do the Trans SAP, as long as you respect that medial border or the pedicles, you should be safe, correct?
Absolutely, exactly. That's also true. As long as you don't ream beyond the medial border of the pedicle, you're not going to be in the lateral recess. Accidental over-resection of the SAP or the IAP. This is one of the things that I hear the most about a disadvantage of a Trans SAP approach. But the thing is, I think if you dock appropriately and you look at the individual anatomy and really figure out where you want to dock And as long as you dock in the ventral 50% of the SAP, as long as the tip of your docking Jamshidi is ventral to the joint line, I don't think that's really going to happen.
Well,
So
plus,
here is
in that particular case, the amount of SAP or IAP that you resect is far less than what you would do even with a traditional tubular discectomy. You're still, with a tubular discectomy, you're still removing almost 1/3 of that entire facet complex, and with this approach, it's a minimal amount.
well, and to that point, you're absolutely right. Of course, with a traditional dorsal translaminar or tubular approach, you are taking medial facetectomy. But with the Trans SAP, with this type of reaming, you're really not even getting into the joint. It's really the non-articular surface of the joint still that you're reaming in the majority of cases. The AP trajectory marking on the skin. So this is just sort of how I actually do the targeting. The interesting thing about the Trans SAP approach, especially the way I've been taught it, is that you don't really have to kind of be worried about, oh, how far do I have to be off of midline for this at this level? Is it 8 to 10 at this level? It's really, really quite simple, and I'm going to break it down right here. So on the AP, you basically just take a line where you think you need to go to access your pathology. So keeping in mind that you want to still dock closer to the caudal part of the foramen, and that you have a 30-degree angle on your endoscope. So, if you have a caudally extruded paracentral disc fragment that is medial to the caudal pedicle, well, then you're going to take a much more rostral to caudal trajectory. Conversely, if you have a disc herniation that is mostly in line with the disc or even slightly rostrally migrated, then you're going to take a much more flatter parallel trajectory to the disc. The beauty of this is, even if you're taking a flatter trajectory to the disc, because you're going Trans SAP, because you're docking on bone, there's much less risk of an exiting root injury. So once you mark this line, I mark this on the skin, and then I just follow that line all the way out laterally until on the lateral, I can see that the tip of the Jamshidi is at the interspinous line, which is represented by this. And so from that line, I know I'm going to be able to get the SAP at an angle where I will be able to get into the canal and see the lateral recess very effectively. And I'll explain that a little bit more, because it's not really quite, sometimes it's not, I didn't really understand it.
So just going back to the AP and lateral fluoros, just so the viewers can understand. So in the AP view, you're placing that Jamshidi needle, and then you're drawing a line, correct, on the skin.
Correct.
And then you switch to the lateral with that Jamshidi still sitting on that line, correct?
Oh no, sorry. So and I'll show you this in a few images in a second.
Okay.
So going back to the concept of on the lateral, why do you target at the spinous process line? So you'll find that if you look at any of your cases, if you are trying to go Trans SAP, you are targeting the lateral recess, typically for something in the foramen. I mean, the majority of disc herniations are obviously not extraforaminal disc herniations, but paracentral and in the canal. So if you are targeting the lateral recess, like in this case, for example, this is the trajectory that you want, and you will be exactly traversing the ventral 50% of the SAP, and most of that will be the non-articular surface of the SAP. And if you take a line and you draw it out from the spinous process, that convergence is going to be on, that convergence is the trajectory that you need to take. So wherever you start on the skin, as long as it's on the spinous process line on the lateral, you will get this trajectory that you need. And the beautiful part about this is that this standardizes it for every single patient. So for a skinnier patient, you're going to start much closer to midline, whereas for a really large patient, you're going to be much farther away from midline. But as long as you know that you're starting at the plane of the spinous processes, then you're going to get the trajectory that you need. Does that make sense?
It does.
And so again, this is just an example. So again, if you, so for, for this type of case, you would draw this line. And so this is represented by the line that I've drawn here. And so basically then I switch over to the lateral. Now, obviously I've already started the dilator work here, but at this point, I just switch over to the lateral. And then while I'm on the lateral, I just drag my Jamshidi needle along this line until the line is at the interspinous line on the lateral shot. Does that make sense?
It makes perfect sense, and that's a nice representation there on your slide. I think that makes it
Yeah.
very, very clear.
So yeah, exactly. So you just draw this one line, and that's the trajectory that you want on your AP, and then you just follow it out laterally until you get to the interspinous line. And so that's a very standardized way of doing it. It's easy to do it for anybody. You don't have to think about it. You don't have to draw out all your lines. You don't have to measure. You just know that as long as you fit this trajectory and criteria, then you will be able to access the SAP. From that approach, you can target the SAP. You can see at this point, I'm touching bone in this particular fluoro image. And so the tip of this needle is just ventral to the joint line. And really, if you look at the entire joint, this represents really, maybe a quarter of the entire joint. So it's the very ventral lateral aspect of the SAP. So again, you're not reaming out the entire SAP. You're not destabilizing the joint. And so here I have advanced the Jamshidi needle at this point, and you can see on the AP, I'm just a little bit beyond the medial border of the pedicle, but that's nothing unusual. I'm still completely docked in bone. And then I've exchanged for the guide wire. Here's the dilators. You can see what the dilators look like. It's directly on target to the ventral SAP. And then sequential dilation. And then finally, this is the working channel once you've inserted it. So what you want to see is that the tip of your cannula is at the medial pedicular line, which tells you that once you insert your scope, you're looking directly in the lateral recess. And then on the lateral, what you want to see is that you are well behind the posterior vertebral line. That tells you that you are dorsal enough that you are looking directly into the canal. And so this is just a sort of a full case example. You may have seen this before. I've shown this on my LinkedIn. I thought this was a great case for Trans SAP. This is a 77-year-old female. She has known L3 to 5 spondy and stenosis. She's had chronic pain from that for years that she's dealt with. She's very independent. She lives alone. She drives. She walks with a walker. But she came in with 3 weeks of severe worsening low back pain. She had bilateral leg pain, right worse than left. She's basically bedbound. She couldn't even sit up in the bed. She had urinary retention, and she basically hadn't walked for 2 weeks. So she was dragged to the emergency room by a family member. She had a fairly non-focal exam. This was her CT scan. It was pretty unremarkable other than her known issues. On the MRI, she's got her known stenosis at the L3, 4, and L4, 5 levels. And then, of course, what we picked up on was that she had this large central herniated disc, massive disc with conus compression. And so she had a conus medullaris syndrome and a very central disc at L1, 2. So, I think, for anybody who doesn't do transforaminal endoscopy, this is essentially a TLIF operation, right? I mean, you're basically committing somebody to a fusion because of the amount of bone and the facet joint you'd have to take to work around that space, especially with the tip of the conus right there and limiting your retraction of the dura. So I thought this was a great case for Trans SAP because I wanted to make sure that I took a lateral enough trajectory that I would be able to look central enough. And I also wanted to take off as much of the SAP up front so that I would have as big of a working window as possible looking into the foramen. And I thought this was perfectly appropriate for that. So this is the pictures of the targeting, the reaming. Here's the channel placement. You can see that I'm very dorsal with my docking here, which was exactly what I wanted to see. This is the view. This was a right-sided approach. So the superior surface of the caudal pedicle, L2, is on the left here. It becomes the ventral SAP here. This is just a picture of me doing a little bit more foraminoplasty with the drill. This is the ventral SAP. Here's ligamentum flavum, lateral recess, epidural fat, and then dura tucked away underneath that, and then the PLL. And so here we're able to slowly work here. Thecal sac, you can see that I'm looking underneath the dura here. There's the contained disc herniation, and even just sweeping the bipolar dissector underneath the dura just caused so many of these large fragments to just extrude out. And then, of course, with the semi-flexible grasper, that's how you get the ability to reach in to central pathology, still under direct visualization. This is representation of looking rostral, caudal, and across, so you can see how much of a reach you can get with the endoscope.
Yeah, could you go back to that slide there for a second? I think this is a really nice representation or demonstration of when you do a foraminoplasty and you resect some of the facet, your ability to manipulate the tubular retractor and therefore the scope allows you to reach so rostral and caudal and really do a complete, to decompress the canal completely. So you have a lot of degrees of freedom here, and you've protected your exiting and traversing routes. And I think this is a really great representation of that.
Yeah, thank you. I think it's just amazing what you can do with the scope. And then here is sort of getting closer to the completion of the procedure. You can see the PLL and the annulus here. It's now getting pretty redundant because all of the disc herniation is essentially gone at this point. You can actually see the ventral dura. You can see the traversing nerve root lateral to the ventral dura, and then you can actually even see the contralateral traversing root all the way on the other side. And then at the end, you can see the void created and then complete decompression dorsal to ventral of the thecal sac. And so this patient drove herself back to my office 2 weeks later. She did absolutely beautifully from this case. Interestingly, she wanted to see me again 3 months afterwards for worsening radicular symptoms from her previous and known L3 to 5 structural abnormalities. And so we got this follow-up MRI, and this was, again, a reminder of the pre-op MRI. And then you look at the post-op MRI, and the disc herniation is obviously completely gone. But the most amazing thing I think about this whole picture is the fact that, there's still really, plenty of facet left here. I don't think there's really that much, resection of the actual joint. And then you look at the posterior tension band, the muscles, the attachments, everything beautiful, clean, preserved, which is exactly the way you want to see it. So in summary, I think you have a decreased risk of DRG injury doing it this way because you are essentially guaranteeing that you are going to ream directly into bone when you go Trans SAP. So again, less chance of aberrant reaming, higher volume of upfront foraminoplasty. So there's more room for the scope to move around. And of course, I think if you're also doing a complex case and you're taking more time in the foramen, kind of like how people say time in the psoas is important for minimizing femoral nerve issues or even just sensory issues when doing trans psoas surgery. I think time in the foramen is also important, but if you have a higher upfront foraminoplasty, I think you have a little bit more leeway there. You get a more dorsal view of the lateral recess, and your ability to reach more central pathology is obviously demonstrated here. So I think when it's done properly, it really does not compromise the facet joint, certainly not the articular surface of the joint. And so I'm a huge fan of this, and this is how I was taught to do it, and this is how I do it.
Oh, this is really excellent. I think this is a really wonderful demonstration of how the technique has evolved and how you've made it more safe, and it also opens up a whole host of other applications such as fusion. This is a safe way of resecting bone. Just a couple of points to clarify. So is your patient awake? Or are you doing them under general? Like this patient that you just did, that you showed, was that a general anesthesia or conscious sedation?
That was a general. So I have done a Trans SAP on an awake patient. I am moving to try to do more awake surgery. Obviously, it's better for the patients. It can be even safer because of the feedback. Unfortunately, as an institution, I still have quite a bit of difficulty in getting my anesthesiologist to participate. They'll find pretty much any excuse not to do it. And so, and there's very few who are willing to do it. And those few who are willing to do it, it's also hard to get our schedules to align. So, it's a work in progress. We're building the awake portion of the program, and it's a slow process, but I think it will happen. And I think you can absolutely do this in an awake patient. I think putting in a Jamshidi needle into bone is no different than reaming through bone, which you do in awake cases all the time as well.
Again, just like everything else, it's all about perception, and that's a really keen observation that we do reaming all the time. I would think that that's a little bit more painful. Just another little point to make. So you when you mentioned you dock the Jamshidi on the SAP, are you actually taking a mallet and getting it seated when you do that? How are you docking it? What do you mean by that?
That's exactly right. So once I feel the bone and on the lateral, I target now. I used to target on the AP, but now I target purely on the lateral. And the reason why I switched to targeting on the lateral is because on the Trans SAP, I know I'm docking on bone. So I'm not really worried about going into the canal. And so I target on the lateral, and once I feel the bone and I know I'm on the ventral SAP, then at that point I will take a mallet and I will mallet the Jamshidi into the bone, and I will basically mallet and traverse the SAP as much as I would essentially with a reamer.
Mm-hmm.
So I still take the Jamshidi basically to the medial border of the pedicle.
And
But at this point, when you do that, you have created a channel through the bone, and then you exchange out your guide wire. The guide wire is sitting in bone the entire time, and then your first dilator, the very, very first one, that one fits through the channel that you created with the Jamshidi.
All right, that's exactly the next question. And then it's the standard reaming like we do for
everything else is totally standard after that. Yeah.
Well, I think this is wonderful, and I think it also opens up a tremendous number of opportunities for doing different types of surgeries like synovial cysts and again fusions and like you said, even tumor work. So this is really exciting, and I'm really thrilled that you're able to share this with us, and you made it so clear. I think other people will be able to watch this presentation and be able to adopt it in their practice. So I really thank you very much.
Thank you for having me. It's always a pleasure to chat with you, and it's an honor to be able to share this technique. And I think it's a wonderful way of doing transforaminal work, especially for the more complex pathology when you have to reach into the canal quite a bit.
I agree.